Hello, my name's Clair Brunner. I'm one of the oncology registrars working in Velindre Cancer Centre, and I'm going to present today about the COVID-19 pandemic and cancer patients, looking at a UK registry and local study and how that shows the importance of rapid research to aid clinical decision making. I'd just like to thank the rest of the team that I've worked on this project with, and that's Ashley Poonking, Tim Gibbons, Libby Batt, Sarah Walters, Professor John Chester and Professor Peter Barrett-Lee, all based at Velindre Cancer Centre. So first of all, I'd just like to talk a little bit about the background to the project. And to do that, I need to take you back to what things were like in the early part of 2020. So in January 2020, coronavirus was an emerging problem. And we saw the first cases of coronavirus confirmed on the UK in January. And in February, there was the first cases of community transmission in the UK and the first case diagnosed in Wales. But by March 2020, we were under lockdown. And as the BBC News headline suggests, that was the month that everything changed and life looked very different as we tried to reduce the risks from this pandemic. And one of the things that was important back in those early times, as we were trying to work out the best strategies to minimise the risks from COVID-19, was to try and work out which patients were at the highest risk from infection. And that seemed to be those who were older or had an underlying health condition such as respiratory or cardiovascular disease or cancers. So what did we want to know? We wanted to work out who was most at risk from COVID-19 infection so that we could try and do everything we could to reduce their risk of catching it. We wanted to know how it was best to manage patients once they got COVID-19 infections on top of a diagnosis of cancer. And we wanted to know how much more risk COVID-19 posed to patients with cancer than to other members of the population. We also wanted to know whether any of our treatments made any difference to that risk, and if they did, how we should change our practice to try and minimise that risk. So what did we do? So on a local level, we set about trying to get the information we needed by setting up a COVID research project group within Velindre Cancer Centre. And we started to collect data regarding the inpatients in Velindre who had a diagnosis of COVID-19. We also made an agreement via the Caldicot Guardians across South East Wales that we would have collaborative working towards collecting the data we needed for this project. And we set up an IT reporting system which generated a database of any patient with active cancer who had a positive COVID-19 result, even if that patient had been admitted to another health board in South East Wales, so that we could capture those patients who weren't directly admitted to Velindre itself. And we all collected data on all of those patients that we could identify, and we analysed them locally, but we also submitted them to the UK Cancer and Coronavirus Monitoring Project. So on a national level, we submitted the data that we collected from our patients in South East Wales to the UK Coronavirus Cancer Monitoring Project. And this is a project that was set up as a UK-wide collaborative research project so that centres across the country could contribute their data to one database to improve the speed at which we got enough numbers to provide meaningful analysis of the data. It allowed us to build up real-time information about what was happening in terms of the numbers of patients being diagnosed with coronavirus and also the outcomes in those patients as the pandemic was unfolding throughout the UK. And that data set is analysed and the results are disseminated via email weekly to each of the centres and to anyone who wants to sign up at the website in the logo on the right hand side of the slide. And in that weekly bulletin, we see how many new cases there have been, and some background about those cases. So what their diagnosis of cancer is, any other comorbidities that they have, how old those patients are, and what's their gender. We also see some information about their cancer, so what type of cancer it is, how advanced it is, and what recent treatment they've had, and then a little bit about the outcomes from those patients. So what did they need? Were they admitted? Did they need oxygen? Were they treated with fluids or antibiotics? Were they requiring ventilation support or admission to intensive care? And each of those weekly bulletins can be 10 pages long, with various graphics showing for example, the age distribution within the data, or the effect of ethnicity, or the outcomes from patients with COVID-19. But just to summarise a couple of salient points from the latest week's bulletin. So we have 66 centres currently participating with the project, and information about 2,320 patients has been included, and of which 5% of patients have been contributed from Wales. One of the important outcomes that we were looking at is what's the risk to patients with cancer who catch COVID-19, and overall we've shown that a mortality of these patients is about 30%, with about 8% requiring admission to ITU and about 6% requiring non-invasive ventilation treatments. The caveat to those results, however, is that in order to get a COVID-19 test back in the early part of the pandemic, you had to be being admitted to hospital. So by definition, this cohort includes only patients in those early months who were being admitted and therefore were at the more severe end of the illness spectrum. In the more recent weeks to months, as testing capacity has improved, there will be more data being contributed about patients who have a positive result but who have not been admitted to hospital. But for the moment, the vast majority of the data set is made up of people who were an inpatient in order to have access to a COVID test. And the other thing that I felt it was important to share is that it's not just the weekly bulletin to the centres and the participants involved in the study, but actually those results are being disseminated on a wider basis, and the registry has led to 2 publications so far, both in the Lancet. So the first publication in June was a paper looking at the COVID-19 mortality in patients with a diagnosis of cancer who were receiving chemotherapy or other systemic active cancer treatments. And what that showed was that having chemotherapy in the 4 weeks prior to having a diagnosis of COVID-19 had no effect on the outcome for those patients. And the second paper has just been published in the last week in the Lancet Oncology, and this has been looking at the prevalence and the mortality in patients with cancer by their primary tumour subtype and by their patient demographics. And what that's shown is it's confirmed the importance of age as a risk factor for mortality from COVID-19, but also that patients with different types of cancers have a different risk. In particular, those with the hematological cancers seem to have a higher risk and a more severe disease trajectory with infection from COVID-19. So what have we found in South East Wales? So we've had 124 patients with an active cancer diagnosis who've also had a diagnosis of COVID-19 infection. Of those patients with a positive COVID swab, about 35% of them also had radiological evidence of COVID, either on a chest X-ray or a CT scan. The mortality from COVID in our patient group was about 23%, and the average length of hospital stay for treatment of COVID-19 was 18 days. with 3 patients requiring non-invasive ventilation and 1 patient requiring admission to ITU. So this conference is all centering around the importance of making a difference with health and social care research. So how has this work impacted on patient care? Well, through both our local analysis of our smaller pool of data and being part of a UK-wide collaborative study, we've built up the biggest data registry of cancer patients with a diagnosis of COVID in the world. And that's been used to guide our thinking and our clinical management throughout the pandemic, and has led to the generation of those publications so far. And the work is ongoing. That database will continue to mature as we follow up these patients for further lengths of time, and as the pandemic continues to unfold. And what we've shown in sort of concise summary is that chemotherapy doesn't seem to increase the risk from COVID-19 infection, but the age and type of cancer are important in determining the outcome from COVID-19 in cancer patients. And these facts and this knowledge and improving our understanding of these risks helps us with clinical decision making and with having discussions with patients about the risks and benefits of continuing with a particular treatment. So in my final slide, I just wanted to focus a little bit on some of the successes of the UK CCMP project. Prior to January of 2020, this project hadn't even been imagined, let alone set up, enrolled in 66 participating centres and have a data set of 2,320 patients. And most clinical trials or projects take a long time in terms of their design and their setup. But one of the benefits of being able to set up this project very quickly and to have an iterative design process, so we've been able to add extra information as it's become important. For example, looking at lymphocyte count. As the data emerged that became an important marker for COVID-19, we've included that into our registry. So it's an iterative process, but that's giving us real-time data collection and timely dissemination of results. So it's a collaborative working has been really important between all the participating centres, as each on our own would have too few patients to be able to analyse and make meaningful conclusions. Having a secure and anonymous centralised data registry allows us to pool that experience from across the UK, and so we can draw stronger conclusions because there's an increased number of patients that can be included. The real-time data collection and the weekly bulletins are very important so that we can monitor outcomes, and as the data set increased in size, more variables can be analysed with increased confidence, and that will continue as the time goes on. And like I said, we've had 2 publications based on the analysis of this data set already, so not only are we sharing the results between participating centres or those that signed up for the email bulletin on a weekly basis, but also those publications will allow the results of this work to be shared more widely on a national and international level. So I think this project nicely sums up the importance of working together in a timely manner and timely dissemination of results in order to make the biggest difference on patient care and hopefully improve clinical outcomes. Thank you very much.